the students may not have come across this situation in your career. So I don't find fault if you are not aware of all these things. So I am trying to give you some more extra points that are needed, not from the examination point of view, but from your knowledge as anesthesiologists, because we anesthesiologists should know something about the other branches and their treatment modalities also. So I am giving something it is not required from exam point of view, but as a general education for our knowledge. So oral cancer can be classified into three types. One is it can be a straightaway malignant tumor, or it can be a precancerous condition, or it may be a simple benign tumor. So these are the three categories of oral uh, surgery, growths. The most common type of malignant tumor is squamous cell carcinoma, because the squamous epithelium is the lining for all our oral structures. And oral cavity consists of the following subtypes. Can be a buccal mucosa, can be an upper alveolar mucosa, gingiva, and lower alveolus and gingiva, hard palate, tongue, and floor of the mouth. So these are the 6 structures from which oral cancer can arise. So nearly all tongue tumors usually occur only on the lateral and upper surface of the tongue. And tumors tend to remain in the tongue but show well-defined routes of infiltration. Mostly they say a very slow-growing tumor. A tongue cancer is not a fast-spreading or a fast-growing tumor, and it is classified into anterior third tumors, which invade the floor after some time. The middle third lesions invade the musculature of the tongue and then subsequently floor of the mouth, whereas the posterior third goes into the musculature of the tongue, floor of the mouth, go to the anterior pillar of the tonsil, tongue base, glossotonsillar sulcus, and mandible also. So the posterior third growths are the most dangerous ones, which can rapidly spread into all the other structures in the neighboring area. So this is the classical anterior growth, this is the middle, and this is the posterior. You can see the involvement already going to the floor of the mouth, lateral aspect, all these things. So this is how they will look like. And squamous cell carcinoma is the most common variety, 95%. And they can be classified as macroscopic and microscopic features. And what are the macroscopic we are more interested in? It can be infiltrative. It will be going into the deeper areas. So this one is the infiltrative type. Then it can be exophytic. That means it is like a growth outside. And that it can be like what is called the wart-like appearance called verrucous. And it can be ulcerated. So these are the 4 varieties macroscopically. And Adam said that ulceroproliferative. Actually, it is a exophytic, infiltrative, verrucous, or ulcerated. These are the descriptions that are given. And most patients with stage 1 and 2 oral cancers do well with surgery. Main treatment is surgery and or radiation therapy. Chemotherapy given along with radiation, which is called chemoradiation, is another option. Both surgery and radiation work equally well in treating these cancers. And surgery before radiation and chemotherapy helps both surgery and anesthesia by preserving the normal nature of the surrounding tissues. Otherwise, they will all also be involved, and that will get fibrosed, and the mobility of these structures and even surgical resection will become more troublesome. So always oral cancers, the first option should always be surgery only. Now for cancers of the floor of the mouth, front of the tongue or inside cheek, hard palate, surgery is the main treatment. And if surgery cannot be achieving complete removal, then there is a high chance of recurrence. So there you have to go for radiation or chemotherapy or both, as the case may be. And factors that affect choice of treatment are related to the tumor and the patient. So if the patient is very debilitated, moribund, anemic because he has not been able to eat properly because of the oral cancer, he may not be a suitable candidate for a wide resection and reconstruction all in one sitting. So the primary site, location, size, proximity to the bone, depth of infiltration are all factors which decide about the treatment. So tumors that involve mandible require specific understanding of the mechanism of bone involvement. So this facilitates the employment of mandible sparing approaches as marginal mandibulectomy or mandibulotomy. So if you are able to preserve the mandible intact, nothing like that, then the patient's airway will be more secure. So defects created by tumor excision can be reconstructed either with a rotation flap, radical flap, or free flap, depending upon the extent of soft tissue and bone removal. So mandible sparing soft tissue defects can be reconstructed with pectoralis major pedicle flap or rotation flap from the cervical skin and subcutaneous tissue. And reconstruction of major surgical defects of the oral cavity usually requires a free flap. And the two commonly done free flaps are radial forearm free flap for soft tissue defects and fibular free graft for mandibular reconstruction, where you take a part of the fibula also and shape it. Nowadays we have the people customized acrylic molds which are available in place of this natural fibular graft, which are used for reconstruction. And so coming to see what are the modes of treatment that are available or been practiced from the 1900 to latest 2020, surgery has been always there. First choice, second is radio, then chemo, immunotherapy, and gene therapy also is now practiced for resistant cases. So this is the history of development of therapeutic modalities for cancer. Now survival rate is very good in cancer. So these patients, if you do see, this is a local resection, small lesion which you can resect in a triangular fashion and then treat the BCN. Then you have here another condition where they are to remove part of the mandible also, and this is a flap which has been, this is the way the incision will be put, and we can resect bone also like that. So these are all the various approaches that are there. So nowadays we have got what is called osteo-integrated dental implants, where you can put the tooth even in the fibula or the other grafts that you put there for the patient to eat. So they are put like that. So this is the implant with the crown, everything looks like that. So instead of just putting it on the existing tooth, you can remove the whole tooth and then screw them into the bone that you are fixing it there, so the patient will be able to chew properly and eat well. Now these are the various flaps for your knowledge. So this is called the deltopectoral flap or DP flap, where you have to take a part of the skin and muscle and then reconstruct the whole thing. So these are all local rotation flaps where you can take the skin from the neighboring area. And this is the tubular graft which is taken and then fixed with the plate and screw here to reconstruct the mandible. And this is a tongue lesion which has been resected. They have taken the forearm flap, radial forearm flap, the skin and subcutaneous tissue, and they have folded it and stitched it. So the patient will have a normal tongue-like appearance and he will be able to phonate and eat also well. And this is the donor side which has been closed. So this is how the surgeries are done. And coming to the radiation therapy, sometimes the examiners, I was watching one of the videos, and the examiner was asking about the chemotherapeutic agents and radiation agents because the examiner was from a cancer institution. So they wanted to find out whether the candidate knows all these things. So just that gave me an insight that we can just talk a few things about that. So the radiation is varieties are there. but the ultimate aim is to reduce the size of the growth and prevent it from further growing. So IMRT or intensity modulated radiation therapy combines a highly advanced computer program with a metal device called collimator. So prior to start of the radiation therapy, a CT scan will be done and a 3D PET CT, and the radiation compared to the older days, the radiation rays will not only destroy the cancer cells but also affect the neighboring cells. But in the current era, they want the penetration to happen only in the tumor and not destroy the neighboring cells. That is the biggest advantage in the current radiotherapy programs. So the approach is to deliver more precise dose of radiation to the tumor while reducing the exposure of the healthy tissues to that. So this is called intensity modulated radiation therapy. Then there is an image guided radiation therapy where ensure accurate position again and map, and then once the tumor starts regressing, you have to reduce the dose of radiation so that it will not spread it to the normal tissues. So that is called image guided radiation, where you repeatedly watch the size. Then adaptive radiation by repeated planning. Again, after the size reduces, you reduce the dose. Then brachytherapy is where you put in the needle or the pellets, and the slow release of this radiation will happen to destroy the cell growth alone. So you directly put it inside the tumor itself. So it involves the placement of radioactive material in the body. Then the current is proton therapy, which is done by using what is called cyclotron. It sends high energy beam of protons through the skin towards the tumor. And the proton beams do not penetrate beyond the tumor, so it reduces the damage to normal tissues. And chemoradiation is a combination of chemotherapy and radiation. So chemotherapy increases the sensitivity of the tumor to radiation. So cisplatin is the commonly used drug. So you treat the patient with cisplatin. Along with that, when the patient is taking this drug, you give the radiation also. So you have 1, 2, 3, 4, 5, 6 options. Intensity modulated radiotherapy, image guided radiation, adaptive radiotherapy, brachytherapy, proton therapy, chemoradiation. So this I have added in case you are asked about it in the examination. And coming to the chemo drugs that are used, the commonly used drugs are cisplatin, carboplatin, fluorouracil, paclitaxel, docetaxel, and hydroxyurea. Does this name sound anything to you? We have seen in an earlier class for the railway PGs where we have talked about this drug,
Sickle cell anemia.
hydroxyurea. Where do you use it?
Sickle cell anemia, sir.
Hmm?
Sickle cell anemia.
Yes, we have used it extensively. So less often used drugs are methotrexate and capability. Why sometimes the examiners ask you is there are side effects of chemotherapy drugs which are relevant to anesthesia. So of course hair loss is not very important. Mouth sores, loss of appetite and weight loss, nausea, diarrhea, vomiting, diarrhea, skin changes, and also some drugs increase the chance of infections from because of low white blood cell, and it can cause bleeding because of low platelets, and it can cause tiredness because of anemia. So these are the side effects of chemotherapy, and also some drugs are able to cause some fibrosis in the lung, produce a picture like COPD. And cisplatin can cause neuropathy also, and cisplatin can cause kidney damage also. So urea creatinine can get elevated and renal damage can happen. So you have to know the side effects of this drug, and probably that is the reason they were asking about it. Now this is the case scenario. What I told you, it's a case of CA tongue posted for wide excision, neck dissection, and flap cover. And so history taking, you asked about the age, sex, onset of the disease, how the disease has been progressing, when he first noted the ulcer or the defect in the tongue, how fast it has been increasing, When did he notice the swelling in the neck? What about pain, bleeding, eating problems? Because some people are not able to eat, they don't eat, weight loss, bad odor, and tobacco chewing habit, pan chewing habit, alcohol intake, and then HIV infection because of promiscuous sexual activity or recreational drug use, both can produce sexual and HIV infection. And then previous treatment with either surgery, patients coming with recurrence after radiation chemotherapy, they are more challenging than the original first time patients. And comorbidities and their treatment status, any dental problem like dislodgement of the tooth, like what you said, no loose tooth. So these are all the points that you have to ask in the history. Coming to the examination, make a general survey of the patient's nutrition, anemia, and see how far that oral cancer growth is very prominent. And some patients become psychologically upset and depressed because of that. So these patients may become delirious or behave badly in the post-op, even if everything goes on well. So pre-op counseling and encouragement is very, very essential. And then go for systemic examination, out of which airway assessment becomes the most important, which you assess by clinical as well as endoscopy also. And then other system involvement because of cancer, like treatment, even like radiation or chemo and surgical site recurrence. Now in tongue, floor, mouth, usually they are associated with Christmas or fixed immobile tongue and limited mandibular space. So how do you find out the mandibular space? What is the test that can be done to find out the limited mandibular space? Jay Bharti, are you there?
Yes, sir. Yes, sir.
How can you find out the limited mandibular space? What test can be done for that? Simple clinical test.
Protrusion of the mandible. Upper lip
Ah,
bite test.
upper lip bite test. Exactly.
Yes.
Excellent. Upper lip bite test is the test done to find out the mandibular space. Then going to preoperative evaluation should be face mask ventilation should be possible or not. That is the first thing you have to evaluate. If laryngoscopy and intubation planned, is it going to be easy or difficult? That is the second question. And if you are going to do an awake fiber optic intubation, will it be possible without causing any bleeding or ulceration or dislodgement of the tumor? And if there is a need for emergency surgical front of neck access, is it going to be possible? So please remember these four questions because the examiners may ask you this with regard to the airway management. Whether mask ventilation is going to be possible, whether laryngoscopy intubation possible, if you are going to do an awake technique also, are you safe to do that without causing ulceration and bleeding? And if their front of neck access is possible. So these four things should be told in the examination without forgetting. Then coming to the cancer, you can do the investigations as a routine plus all the routine investigations for a major surgery. And how do you pre-optimize the patient? You have to make sure, luckily, Dr. Jay Bharti's patient has been eating well, maintaining his weight. But if their nutrition is not maintained well, you may have to give them nutritional supplements, even parenteral nutrition may be needed, correction of anemia, correction of coagulation profile, and proper control of comorbid conditions like hypertension, diabetes, heart disease, COPD, or endocrine systems like thyroid, and reservation of compatible blood, antibiotic cover as you do for all routine cases. And because these are elective surgeries, the cancer surgery, the oral cavity is not a life-threatening emergency surgery. So NPO advice, and in patients who are not able to take the food properly, you may have to give them pre-op fluid replacement also during the fasting time. Then coming to the airway management, you have to make a plan before you start the case. So whether it is going to be regular induction and intubation, or whether it is going to be a awake fiber optic, or if there is chance that you may try for a trial into the induction and intubation, or straight away go for a planned elective tracheostomy before and or do an endotracheal intubation during surgery followed by tracheostomy at the end of the surgery. So these are the options that you have to keep in mind. One is regular induction and intubation for small tumors with not much of mandibular resection and all that can be managed in the regular way, or mouth opening limited and other condition, awake fiber optic intubation, or trial induction and intubation in intermediate cases, or elective tracheostomy before starting the surgery, or intubation and surgery followed by tracheostomy at the end of the procedure. So what are the effects of anesthetic agents on cancer surgery? That also is one of the articles which has come in the World Federation of Society of Anesthesia recently in 2020. So I thought examiners may suddenly ask that also. So there are the pathways which causes aggravation of the cancer. One is hypoxic induced factor 1 alpha, insulin-like growth factor, epithelial growth factor, nuclear factor kappa, vascular endothelial growth factor, neuroepithelial transforming 1 gene, natural killer cells, cytotoxic T lymphocyte, T helper cells. These are all the factors which stimulate the cancerous cell growth. So their actions, some of them are angiogenesis, causing glycolysis, causing cell proliferation and suppression of apoptosis, cancer invasion. So these are all the ways by which they cause that. Now coming to our anesthetic agents, volatile anesthetics increase this factor, hypoxic inducible factor 1A. Propofol decreases the value of this. So naturally, if you give propofol, you will be reducing this factor and the chances of recurrence or spread of the cancer will be less. Again, volatiles increase. So using volatiles, if you see, it increases most of the majority of the pro-cancerous agents or bodies in that. And earlier, when I started my work with this oral cancer surgery patients, surgeons said don't infiltrate local, you will be dissipating the tumor from the one side to the normal side. But now that theory has been completely disproved. So local anesthetics decrease this endothelial growth factor as well as NFP beta, I mean kappa B. So nowadays they encourage infiltrating local anesthetic with adrenaline during dissection in the tissues surrounding that. So the spread is or recurrence rate is very much reduced. And opioids also to some extent increase these factors, and NSAIDs reduced. So propofol and NSAIDs, they reduce the stimulating factors, whereas volatile anesthetics and of course steroids is the third one which reduces all the other and local anesthetics. So four things: propofol, steroids, NSAIDs, local anesthetics are safe in cancer patient usage, whereas avoid volatile as much as possible. That is the reason why nowadays they say you can use these drugs for easily, but better to go for Tiva if you want to avoid usage of uh, the stimulating factors. If you want to reduce, avoid volatile by Tiva. So local anesthetics may alter cancer outcome by direct result of their immunomodulatory effect, and opioid sparing effect of sympathetic block attenuate the association of immunosuppression. So both the ways the local anesthetics are very, very useful. And blood transfusions can cause inflammation and immunosuppression that can subsequently encourage cancer recurrence. So as far as possible for these oral cancer patients, try to maintain their hemoglobin well with adequate nutrition and supplementation preoperatively, and manage intraoperative blood loss by proper hemostasis and injection of local anesthetic with adrenaline so that you can avoid blood transfusion in these patients. And opioids have immunosuppressive policies including reducing activity of natural killer cells and neutrophils, which can accelerate cancer progression. And opioids can directly influence cancer cell growth in vitro. So by the effect on their new opioid receptor in the overexpressed in wide range of cancer cells. So studies have mostly indicated increased tumor growth and metastasis if you use dexmedetomidine. So better not to use dexmed in this surgery also. Steroids are commonly used in perioperative settings for three reasons. One, they can cause anti-emesis, they are anti-inflammatory, and nowadays it is part of analgesic regimen also. So dexamethasone, which we are using, has got three important activities: anti-emetic property, anti-inflammatory property, and analgesic property. The current evidence involving steroid use in cancer surgery, even though it is insufficient, but it is used as a part of the treatment. Potential benefits of NSAIDs include opioid sparing effect, so all the bad effects of opioids can be avoided, and it also alters the epithelial growth factor and nuclear factor kappa and inhibition of prostaglandin induced immunosuppression. So it is got some protective effect in cancer patients. And there is a new terminology called RIOT, which is considered as the new endpoint in oncological surgical research. That is return to oncological treatment. So after surgery has been successfully done, some percentage of patients may require post-oncology, post-resection oncology treatment in the form of radiation or chemotherapy. That is called return to oncological treatment. But the acronym given is RIOT, not REOT. The RIOT is a return to oncological treatment. So a reduction in time to return to oncological treatment has been found to happen infiltration of ropivacaine in the post-anesthetic period. So patients where we have infiltrated ropivacaine for pain relief in the surgical wound, those patients are able to return to oncology treatment much faster. Now coming to the practical steps in the anesthetic management, supposing you go into oncology anesthesia after your DNB or your graduation, then these are all the methods by which you manage these cases. Being an elective surgical procedure, there is adequate time for MPO, so you can prescribe MPO for 6 hours. And patients who have mildly dehydrated or inadequate intake patients, you can give them IV fluids in the form of plasmalide 2 ml per kg per hour. Then you can prescribe oral or parenteral pre-medication in the form of angiolysis if patient is able to swallow. But if there is any airway obstruction, better avoid any form of sedation. Okay? So based on the condition, you can do that. General anesthesia is a preferred technique as these surgeries are long duration surgeries and need oral dissection, and except small tumors which can be done under local anesthesia. So airway control achieved as per plan. If endotracheal intubation is possible, is done by nasal route, either with a nasal ray tube or a flexometallic tube. Otherwise, elective tracheostomy under LA may be the starting way of controlling the airway. So for the benefit of Dr. Jayabharti who has not seen, this is the nasal ray tube which has been given into a nostril and it has been correctly fixed, and even the circuits have been properly supported so that no pressure effect will be there and fixed. So securing the airway and controlling the airway is very important because once they start the surgery, the access to that will be very, very limited. And you can see there is a transparent dressing put over the eyes to protect the eyes. So that is the nasal ray tube which is being intubated. This is what you described. This is the flexometallic tube which has been passed. So that can be fixed either with a elastoplast like this, or you can take sutures to the septum and fix it. So you see how much care they are taking to keep the tube in position, because any displacement of the tube intraoperatively will be a disaster, because you will be paralyzing and controlling the ventilation, and if the tube slips out of the trachea, you will be finished, and patient also will be finished, and surgery also will finish at the same time. So secure ET tube well with the tapes and sutures so that intraoperative tube displacement is not taking place. Eye protection and prevention of pressure on the face by breathing system is important, and slight head up tilt to aid venous drainage, and pressure on the occiput can be reduced with a soft head support. So this is called the gel head, head rest, GEL, gel head rest. This is a soft, most of you would have seen bean bags in homes where you can sit. So it is something like that which can prevent a pressure sore or pressure necrosis occurring in the soft tissues. Now, if you are planning to do an elective tracheostomy, this is the tracheostomy at the end of the surgery. You can see the patient is already having some dressings, everything. So probably the surgery was done with the nasotracheal tube. Then at the end of the surgery, you have can put in the tracheostomy. This is, can we judge what is this? This is the intra-op tracheostomy. You can see still surgery is going on. So surgeon at the towards the closure, before he closes his wounds, he does the tracheostomy and asks you to remove the tube from the nasal end. And so the raw areas indicate that this is a, and you can see the gloved hand of the surgeon connecting the tracheostomy tube to the circuit. So this is end of surgery tracheostomy after dressing everything. This is intraoperative tracheostomy before wound closure. And can you make a guess what is this? Or what is the difference you see between these two pictures and this picture? Vidya, Elmalai, Sunita, anybody can answer. Are you all there?
Sir.
Are you all there? Yes or no? Auntie, say yes
Yes,
or
sir.
no.
Yes,
Let me
Yes,
see,
sir.
let me see whether you are all here or going away from the class. Because I'm
Sir.
not seeing your face.
Neck
What is
flap. Neck flap.
what is this? This is the past.
Flexometallic tube is placed.
This is a flexometallic
Flexometallic.
tube in the trachea.
Pasted in.
Okay. So this has been given, anesthesia is given through this, not just for maintaining the airway. Okay. So this probably this patient had the tracheostomy at the beginning itself, and anesthesia is given with the flexometallic tube. Okay. So this is very, very important. So tracheostomy at the beginning of surgery, flexometallic tube in the tracheostomy tube. That is your observation. This is not the regular, this is a regular tracheostomy tube through which you have attached your circuit. This is also a regular tracheostomy tube, whereas here it is a flexometallic tube. So whenever the surgeon wants the tube to be away from the surgical field, you always put the cupped flexometallic tube into the tracheal opening, inflate the cuff, and bring it onto the chest and suture it or plaster it there. Okay, that is how you fix it. So all monitor lines to be appropriately placed as per the plan for surgery. For example, if the patient want to do a pec major flap, ECG needs to be fixed on the back. For radial forearm flap, no IV line or BP cuff on the donor hand. And in such cases, you can put in an intra-arterial line for maintaining and measuring the BP as well as ABG analysis if you want to do. So this is how you put the ECG leads on the back of the patient before you make them lie down, not on the front. Maintaining normothermia by body warmer, IV fluid warmer, and adjustment of ambient temperature is recommended. So if the patient, they are not going to do any prefibular flap or any involvement in the lower limb, you have to cover all the thing, and most of you would have seen this body warmer, how it's being used. And TED stockings and DVT prophylaxis to be ensured. So this also most of you may be familiar with. So this is another thing that you have to do. And two wide bore IV lines for fluid replacement. Very rarely you may need a central line, but central line through the IJV may be problematic because they are going to do the dissection in the neck and chest. So even subclavian may be troublesome. So if at all you have to go for femoral, and femoral is always prone for infection and other things. So wide bore IV with a good access is very, very important. And after securing the airway as per plan, whether by induction or awake, anesthesia is induced with IV induction agents, ventilation controlled with muscle relaxant, and you can do opioid sparing analgesia by planning your pain relief with LA infiltration and LA and adrenaline infiltration, and maintenance either by inhaled volatile anesthetic agents, or if you can avoid that, you can go for PIVA. Adequate hydration, blood pressure maintenance, normal acid-base status, and temperature are essential if a microvascular surgery is planned. And the surgeon may request for anticoagulation in the form of unfractioned or low molecular weight heparin. So you have to monitor. Majority of them we don't reverse this with protamine as we do in cardiac cases. So patient will continue to receive these anticoagulants in the post-op also in some units as per the protocol. So we have to be very watchful for bleeding. And this is enoxaparin. Most of you would know. What is the one thing you should notice before administering this compared to the heparin?
Renal profile.
Renal? No,
Renal
this
parameter.
drug. When you take the drug, what should you look into the carton or the drug? What is this written here?
Subcutaneous.
It is for IV or subcutaneous use. But some of the low molecular weight heparins are manufactured only for ST use. Okay, so please look into the carton or the package to see whether it is both for IV and ST use. So some preparations are there which are only mentioned for subcutaneous use, which you should not give IV. So please always watch that before administering. And at the end of surgery, decision to extubate or retain the ET tube depends on the extent of resection, airway stability, likelihood of edema or obstruction. These are the 3 points that you have to keep in mind. So if you think any of them are going to be there, always selectively ventilate the patient through the tracheostomy and then wean them off slowly after 24 to 48 hours when all the edema and bleeding, everything is settled. In case of difficult airway, it is safer to extubate, leaving an airway exchanger in case you plan for extubation and feel that it may be difficult to re-intubate the patient. Never take out the tube without an airway exchanger. And if an elective tracheostomy has been performed, routine care of tracheostomy to be done until it is removed. So this is the picture where you can see the patient. This is the airway exchanger. Okay. So probably this has gone in through the nostril like this, and patient is receiving oxygen via a face mask. So this can be retained. And sometimes we can give oxygen through this also here, and then in case of any need, you can railroad the tube through this back into the trachea. So that is the thing that you have to keep in mind. So these are all the points I thought I will tell you. So any questions or any doubts on that? Doubts? All clear?
No, doc.